Hello, Megan May here. This is video number 3 of our 4-part series on blood and cardiac infections. And in this video, we're focusing on viremias and viral hemorrhagic fevers, which I just realized is spelled wrong in this slide. Apologies. Should be a no there. All right. So, once again, this was video number 1. This was video number 2. You are here, and this will be 4. Okay, so diseases featuring viremias. What we mean by viremias is having this state of viruses in the bloodstream and causing their primary site of infection in the bloodstream. So what you'll see in video number 4 is that we have a similar set of infections caused by bacteria, and we refer to those as bacteremias. But this is for viruses whose primary site of infection and disease manifestation involves infection of blood cells. So many to most of these are arboviruses, and many to most of these you have met before. You've actually seen a version of this slide before in block 1. So this was when we were describing arboviruses. We had a big list of them. So we have dengue virus, West Nile virus, yellow fever, chikungunya, Rift Valley fever. And what we did with these guys was we lumped them into little groups by things they had in common. So for instance, everybody's spread by mosquitoes. Some of them you have to note travel history, things like that. We'll get back to these in a second. But the key clinical features of these guys is, once again, present typically as severe influenza-like illnesses. You have fevers, malaise, myalgia. You just have patients who don't feel well, and they're quite clearly sick. But it's not super obvious that it's confined to one area of the body. It's sort of a diffuse, I don't feel well. Some of these will give rashes, and some of them will have some unique complications that make them a little easier to point towards. But this is the main picture that you see with these guys. I don't feel good, I hurt all over, and my life is not happy right now. So as mentioned, again, all of these are spread by one species of mosquito or another. If you have patients coming in presenting in this way, one of the most important questions you can ask them is about their recent travel history. Patients that are infected with dengue, chikungunya, yellow fever, Rift Valley fever, or Zika are going to have in their travel history something fairly unique. For dengue, it's anywhere across the world in the tropics. For chikungunya, same goes. For Rift Valley fever, it would be on the African continent, or to a lesser extent, the Arabian Peninsula. For Zika, that would be Southeast Asia, or Central to South America, or the Caribbean. And yellow fever, Central to South America, and now North Africa as well. They are currently having a raging yellow fever outbreak, if anyone's interested. Another important question to ask of patients who come in like this is, what is their vaccine history? And in this case, that would be important for patients with yellow fever. It is also important, again, as we mentioned, in the not too distant future, going to be important for dengue patients. As mentioned a couple of months back, there is a dengue vaccine that has been licensed in Mexico and some other Central American countries. It seems to work quite nicely, and I would not be surprised to see it licensed in this country in the not too distant future. In addition to that, jaundice is a common feature that you see, certainly in yellow fever. That's where it gets its name. But you can also see it in dengue patients if they have progressively worsening hemorrhagic symptoms. Speaking of which, some of these guys also have complications of hemorrhagic fever. We'll talk about them in more detail in a couple minutes, but those would be dengue, Rift Valley fever, and yellow fever virus. particularly yellow fever and Rift Valley fever, this is not a majority of patients. It's quite unusual when it happens, but it certainly can happen, and it can be life-threatening and quite severe when it does. For dengue, we know a little bit more about the mechanism of how hemorrhagic fever develops, and so we're able to identify a really key risk factor, which again, we'll get back to in a few minutes. In these influenza-like illnesses that present with severe pain, not just kind of ache all over, but it feels like my bones are breaking level pain. That is where you might want to look closely at dengue or chikungunya, and diseases that feature limb rashes. Viremic diseases that feature limb rashes would be Zika, Chick, and dengue. And with dengue, again, you've got, you see limb rashes in the hemorrhagic fever form. Okay, so those are our viremias. There are other viremias, meaning that there are viruses that you see causing effects via the circulatory system, particularly in the lymphatics, but we typically think of them as primarily targeting other parts of the body. And the two big ones that come to mind for me are Epstein-Barr virus and cytomegalovirus. And so we have already discussed these in Block 1, so please do refresh yourselves on them. And bear in mind that these are technically viremias as well. Although, again, I don't think of the circulatory system as being their primary site of infection. But go back and check these guys out. We learned about them under the broad category of herpes viruses. All right, so with that, those are all of our viremias entirely, and now we're going to talk about hemorrhagic fevers, which is always very exciting. So viral hemorrhagic fevers sound like a single thing, but it's actually a very diverse group of infections. We tend to think of these as incredibly dramatic and horror movie level scary, and some of them certainly are, but others are actually not quite so overt, and they have unacceptably high mortality rates, but certainly not uniform death sentences. So the clinical signs of hemorrhagic fever are listed here, and I wanted to put this schematic in, and this is based off of, it's kind of a multi-part picture here, but the top part was put out by the BBC, and the bottom part, the diagram, was adapted from the Centers for Disease Control by Melina Yingling, and it's pretty nice in that it gives you kind of a body-wide view of what's going on and what clinical signs appear when in the process of hemorrhagic fever. So this is the absolute worst version of hemorrhagic fever that's depicted here, and again, this was based on Ebola, but some of these processes are fairly consistent throughout. It's just the degree to which they happen differs from virus to virus. So the clinical signs of hemorrhagic fever start in a kind of nondescript way, and then they pretty rapidly progress. People will have fever, they'll be exhibiting malaise, diarrhea, vomiting, headache is another big one. Not very defined and helpful, but a couple of days later, it becomes even clearer that something is very, very wrong with these patients. Then they'll start exhibiting lethargy and oftentimes confusion. A lot of that is due to dehydration, and the starting phase of hypovolemic shock, but it's not quite so apparent yet that that's what's going on. After that, what you'll start seeing is the emergence of petechia, and sorry, that's actually two words, somehow the space got lost, petechia and ecchymosis. And so what ecchymosis are is basically the merging of a whole bunch of petechia into one big giant lesion. Petechia, again, pinpoint hemorrhages under the skin. from minor leakage from the capillary bed. In some of these more severe hemorrhagic fevers, this can progress to overt hemorrhage, where you have kind of the stereotypical view that we all have of Ebola patients, where they're bleeding from their eyes and their nose and their mouth and everything like that. Often, especially with some of the more minor hemorrhagic fevers, it doesn't get this far. It gets to a petechia ecchymosis type stage, which is a very good thing, because that level of hemorrhage is a signal that you're not going to be around for much longer. Because there's so much hemorrhage and cell destruction going on, often what happens to these patients is they develop a hepatitis and a hepatosplenomegaly for obvious reasons, right? They've got all of this damaged blood coming through circulation, and it's plugging up the spleen and causing it to swell. The hepatitis, where you are in the curriculum, might not be quite as obvious. It will be clearer, I think, once you go over the pathophysiology of hemolytic anemia, but basically a really tight linkage exists between rupture of red blood cells and hepatitis and jaundice. And the reason for that is that a lot of the components within red blood cells, particularly some things like bilirubin, are toxic in their free form. And when you have so much of them, because you have this mass hemorrhage and cell destruction, that really puts a strain on the liver and causes it to inflame and become overwhelmed, and ultimately causes congestion and starts to have the liver start to fail. And when it can't keep up with the processing of bilirubin from lysed red blood cells, that bilirubin just stays in the tissue, and it's got a very intense yellowish color. One of the classic signs of jaundice is, of course, yellowing of the skin and eyes. And so when you see jaundice, it's a hallmark of hepatitis, and when you've got massive hemorrhage going on, that tells you the extent to hemorrhage that you have, that you've induced liver failure in a person who previously didn't have liver problems. When that happens over a course of, say, we're day 9, here we're day 11, when that happens over a course of 2 days, that kind of gives you an idea of how very intense this process actually is. When you have liver failure and this level of hypovolemic shock and dysregulation, that's also going to then stress the kidneys. And so then at that point, while you've got massive internal bleeding and liver failure progresses to kidney failure, that's a one-way ticket here real quickly. So that's basically the pathophys of hemorrhagic fevers, worst case scenario. But how we actually get to this point from the virus-host interaction standpoint is not so consistent from most. The commonalities of all of these is that you have capillary leakage. So if you have an intact blood vessel here, you have your blood cells and your red blood cells and your white cells and your platelets floating along the lumen of blood vessels. What ends up happening during hemorrhagic fever is that these guys end up out here somehow in the tissues and in the capillary beds. And so that is obviously not what you want. You want your blood inside your vessels, not outside of it. In one of two ways, this capillary leakage can actually start happening. The first way is that you just simply have a destruction of the endothelium. So these cells get cracked open somehow and broken open. And then you have a rupture in the vasculature, and then these cells are free to leak out into the tissue. For some hemorrhagic fevers, it's a lot more elegant than this. They actually induce diapedesis and white cell migration into tissues. They basically hitch a ride inside of white cells and then cause them to secrete cytokines that make a mass inflammatory response and wind up damaging the endothelium that way. And the end result is you still have blood out in the tissues where you don't want it, but just the way that you get there is slightly different. Mechanisms, of course, as just mentioned, would be one of these differences, but the other big difference is the extent and the severity to which this happens. When this is happening fulminantly all over your body, that's when you have the massive liver failure turned kidney failure via hypovolemic shock, and then you become dead very quickly. When you have this happening in a little bit more of a controlled way, when you have it happening more locally or more slowly, so that you can have repair happening while this damage is still going on, that's going to make this a much less severe form of hemorrhagic fever, and it's going to make it a much neater and less intense experience. And for those latter versions of hemorrhagic fever, patients have a much better chance of recovering. So mechanistically, as mentioned, you can either crack these guys open by yourself, or you can be a little more clever about it and have it happening in a slightly more controlled way. And so I like to group hemorrhagic fever viruses into two broad categories. You have shredders and you have assassins. So these guys are shredders. These guys are assassins. Clever guys, kill everything in their sight guys. Okay? Which way is better? I don't know. From my standpoint, I'd much rather have an assassin than a shredder. But, you know, it depends on your viewpoint, which of those makes a quote, better virus or a better pathogen. One of them is certainly more deadly than the other. The way that you decide which one you are has everything to do with how these individual viruses infect their host cells. Okay, so we'll get back to that in a sec when we talk about which viruses fall in which category, okay? So first we're going to talk about the shredders. These are the worst guys. These are the ones that cause you the severe over dramatic hemorrhagic fevers. These ones are transmitted via body fluids. So that would be blood, lymph, diarrhea, vomit, tears, whatever, the whole 9 yards. So these guys cause the pathology that they do because they will directly bind on to cell receptors that are very commonly present on multiple cells. So Ebola, for example, binds onto a protein called Niemann-Pick1. And this is present on all kinds of cells in your body, which means Ebola's tropism is pretty global. In particular, when Ebola viruses are in the bloodstream and they start binding onto endothelial cells, they start replicating within them, they start lysing them, and they cause quite a bit of damage to the endothelium. So I described this to a physician once who said, wow, so that's like being run through with a piece of barbed wire. And I thought, that's the best way I've ever heard that described. That's exactly what's going on. There have been a few papers published about potential immune regulation of by Ebola virus and clever inductions of apoptosis and things like that. But I don't know how clinically relevant that those types of processes are, because if you look at the pathophys of the disease, that's not really what you see. You don't see a bunch of apoptotic bodies floating around. You see ripped up endothelium and people bleeding into their tissues. So the simple act of this being no more complicated than a very, very common receptor that's on all kinds of cells, I think that it's as exotic as it needs to be. I don't think it needs to be any more clever than that. So Ebola is the one we talk about most extensively, and just to flag this as something to watch for, as many of you probably heard on the news, there was an experimental vaccine deployed to Guinea in particular, and it seems to do quite nicely. And so futuristically speaking, asking about a patient's vaccination status for Ebola might be quite relevant to do. So the other guys that fall into this category of shredders would be Marburg virus, Lassa fever virus, and Crimean Congo hemorrhagic fever virus. So where you find these guys in the world, there's 3 of them are in one fairly narrow range, and then one of them's a little more expansive. So Marburg and Ebola you find typically in, or historically you found in central to sub-Saharan Africa, mostly Central Africa. Ebola, of course, as we all know, has moved into West Africa. Hopefully it's not established endemicity, but I don't know when we can officially say that, given what we've learned about how long Ebola hangs out in immunologically privileged sites in the body. So who knows? You can still find it in eyes and in semen several months to potentially years later. So here's hoping that doesn't rear its head in West Africa again, but who knows? Lassa fever is found exclusively in West Africa. Crimean Congo hemorrhagic fever has a much wider range, which you can kind of tell by the name. So it was first found in Central Africa, in the Congo, but is also now endemic in the Balkans, hence the Crimean part of that. It's also endemic on the Arabian Peninsula and throughout south central to southeast Asia. So this guy's got the biggest span. It is also unique among these guys in that it's actually a tick-borne disease. And once it is transmitted via tick to a patient, that patient can then spread it person to person via their body fluids. But usually you don't have a person randomly coming down with Crimean Congo hemorrhagic fever unless they've been bitten by a tick that is in contact with exposed and sick livestock. In addition, people can contract Crimean Congo hemorrhagic fever from butchering infected livestock. So this would be a good moment to mention, by the way, that all 4 of these are zoonotic illnesses. Marburg and Ebola have a natural host of bats, but you also find them in non-human primates. Lassa fever has a natural host of rodents, and CCHF is a natural host of livestock. All right, so those are our shredders. Our assassins, on the other hand, work a little bit differently. These are vector-borne, and they can also be transmitted by body fluid exchange, but that is much less common. Okay, I'm going to start over here with Rift Valley fever, and the reason I am going to start over there, and the reason why it's kind of drifting up above assassin, but not quite in the shredder range, is that it's not spectacularly clear what the pathophysiology of Rift Valley fever hemorrhagic syndrome is. There was some suggestions a couple years back that it involved disseminated intravascular coagulation. I haven't seen persuasive evidence demonstrating that for certain. What is clear is that most cases of Rift Valley fever fall into that kind of standard junky influenza-like illnesses about 1% of the time when certain patients develop hemorrhagic fever, and it's not clear why or how. So that's no fun. But one thing that we can say about it, and then again, that's why I haven't put it in one category or the other, because I don't really know how it works, nor apparently does anyone else. One thing that we can say about it that is helpful is that it is also a virus that is naturally occurring in livestock, but there is a vaccine that's routinely given to livestock. And so it's hard to come across Rift Valley fever in an individual unless they have been either hanging around sharing mosquito bites with unvaccinated livestock or butchering unvaccinated livestock. So it's not a very common illness because this has really cut down on its natural reservoir. However, Rift Valley fever is something that is perennially considered as a potential biological weapon. So if you ever come across a case of that, you best tell somebody right away. And that's, I guess, all I can say about Rift Valley fever. All right. The other three we have down here are yellow fever and dengue, and then we've got a surprise in the corner. As mentioned again, yellow fever virus is rarely and occasionally associated with hemorrhagic symptoms, and primarily the way that you see these is manifesting as petechia and jaundice. Jaundice is consistent with yellow fever for many reasons. First being that it has a liver manifestation as well. But when it does get into the capillary beds and cause hemorrhagic syndromes, that makes the jaundice aspect of it all the worse. When you have hemorrhagic symptoms in yellow fever virus, the mortality rate goes up pretty substantially, but that's not surprising. Again, where you find this in the world is in parts of South and Central America and now North Africa. Once again, your flag to look for this is a patient's vaccine status. Although, fun fact, in North Africa, a lot of countries have been closing their borders to would-be travelers unless they can produce a documentation that they've been vaccinated against yellow fever, because a lot of countries are trying to limit the spread. And so apparently a black market trade has opened up in fake yellow fever documentation. So, fun fact. I guess there's a buck to be made everywhere. On that fun note, dengue hemorrhagic fever and dengue shock syndrome have a very clear pathophys. And this is where the assassin idea comes from. So dengue fever virus, in its primary infection causes, as mentioned, dengue fever, this kind of intense, severe influenza-like illness with this terrible pain and this fever and a recovery period of about 2 weeks. It's a very intense disease, but it does not have a spectacularly high mortality rate. When you get a patient infected for a second time by a different serotype, the game changes a little bit, because what happens is you have the antibodies present from the first infection. They are able to bind on to the new dengue viruses that are in the bloodstream, but they're not such a good match that they neutralize it and allow for the virus to be removed by the immune system. So what they do instead is these viruses are grabbing onto these antibodies in a fairly weak way, and then macrophages come along, see antigen antibody complexes, do what macrophages do, and try to opsonize it. They do this very successfully. Unfortunately, dengue's favorite target cells are monocytes and macrophages. So basically, what this non-neutralizing antibody has done is target the virus directly to its host cell that it is trying to get to. So that's clever, right? That phenomenon is called antibody-dependent enhancement, or ADE. Boy, that's terrible. I think I'm making it worse. Sorry. ADE. That's supposed to say. What ends up happening is once you have these dengue-infected monocytes and macrophages, you have them mediating diaphoresis and tissue migration, and then they stimulate all manner of crazy cytokine secretions, which ends up making this massive inflammatory damage right at or near the site of migration into the tissue. And that causes a whole bunch of damage to the endothelium, and that causes leakage of blood into the tissues. So the point here is that is far more subtle than what a shredder would do, which is just destroy the entire endothelium in its entirety. But what dengue does is almost on a cell-by-cell basis, does this kind of very subtle act of destruction. Don't get me wrong, dengue shock syndrome and dengue hemorrhagic fever are severe illnesses. They've got mortality rates between 15 and 20%, which is not good, but it's certainly not Ebola level. So they're, again, much more targeted, much more subtle. So that leaves this guy in the corner. And why is he here? I put Zika down here with a bunch of question marks because of a very curious case that happened about 6 weeks ago. And this case happened in Colorado, in an elderly gentleman who was about 73, and he was a Mexican citizen, and he traveled to Mexico visiting family over the end of the summer, and he came back. What was known, when he came back, he got sick. So what was known about this patient prior to his travels was that he had had dengue fever. He'd been infected, in his youth at some point, and when he was infected, he became seropositive, and life went on as usual in Colorado. When he traveled down to Mexico over the summer, he became infected with Zika. When he returned to Colorado, he got sick, and what became instantly clear was that he was developing a shock syndrome, and he was rapidly having symptoms of hypovolemic shock. He was having leakage into his capillary beds. He had never had a previous Zika infection. This was not commonly seen in Zika patients. But this gentleman, for whatever reason, developed this complication, and he was put in the ICU, and unfortunately he passed away. Another interesting thing about this case was that he actually transmitted Zika to his son, who was taking care of him, and the thought is it happened via either sweat or tears. So this case was unique for two different reasons. But the thing that really struck people was, how did this guy wind up with a shock syndrome? And the thought was this. This had been postulated, you can see by the date here, last June, where people thought, wait a minute, if you think about the way that dengue shock syndrome works, is it possible, if Zika cross-reacts with anti-dengue antibodies, that we could see patients developing hemorrhagic fever and shock syndromes if they're infected with Zika after they've been exposed to dengue? And everybody thought, well, that seems possible on paper, but I hope it doesn't happen yet. It happened to this one patient. It will be very curious to see if this is an ongoing phenomenon. Hopefully not, but it is potentially possible. Alright, so that is the end of the story with viremias and viral hemorrhagic fevers. I hope it was illuminating. One thing that I took away from preparing this was that I did not know quite as much about hemorrhagic fevers as I thought I did, which is always a good thing to realize after the fact. So anyway, alright, enjoy, hope it works, and we will see you for video number 4.